We're going to move on to the next case. The next case is in New York with at Mount Sinai. So Srini, can you hear us? So I should note, by the way, this case is going to be with the multi-electrode array, the globe catheter. This is FDA approved. So
okay, good.
This is available to people. Yeah, we can, Srini. Go ahead.
Okay, hi. How are you? How much time do we have? Just a quick mic check.
You have 5 minutes left. I'm kidding. You have 19 minutes.
No problem.
You're good. You're good.
All right. So welcome to Mount Sinai, everyone. We have a case here, PFA with PVI with the multi-electrode array. My colleagues here, Sam Hanon and Dan Musikantow, the fellow, is John Power. He's sitting outside, and he's going to start briefly with the presentation.
So our case today is a 76-year-old male with symptomatic paroxysmal atrial fibrillation that was recently diagnosed. He became persistent over the last month and is here today for ablation. He's had no prior attempts at ablation. Chad's VASC is 2 on account of age, and LV ejection fraction is preserved.
Perfect. Thank you. So I'm just going to go a couple of slides about the globe. It's a 122 multi-electrode catheter. We can selectively choose which electrodes we're going to target from, and the contact is really based on thermal information rather than impedance, and I'll show you just that. And next slide. So first, what we do is a flow map, and what you're seeing is areas that are white and areas that are dark. And what the flow map is basically using resistive heating and heating the electrodes, and it measures the rate of cooling basically. And so blood is going to cool much faster and is represented by dark there. Areas of contact are going to take longer, and so they're white. So that's what that's measured. Let's go to the next slide. And this is a contact assessment. This is what we do before we go on ablation. It takes about 12 seconds to run, and essentially uses subtherapeutic level of RF energy, and then it measures how much energy is required to raise the temperature by 1 degree Celsius. So it takes about 12 seconds. And once you get, and the same concept, so there you see on the left, areas are cooled and take much higher energy to heat, and are represented are veins, and the thermal tissue obviously heats faster. Next slide. Yeah, so you can select, and you'll see as we do this, anywhere from a pair of 2 to 64 electrodes. And the whole concept is try to get the whole vein and do it all in one shot. Next slide. There's some, I think most of the people know this, but there's a pulsar study, and it just shows, like we all know, the more scar you have, the
well, actually, Srini, this was just presented at ERA, actually. So maybe you just go through it. I mean, so
why don't you go through this, and then I'll get ready over here.
Yeah, no, that sounds good. So the pulsar study, actually, can we just go to the moderator slides for 1 second? Because I want to just show it. So this is from the pivotal trial. And it was a multi-center study, of course. And if you see here, one of the really interesting things about this in the bottom left graph is when you look at the durability, it was 95%. And what's interesting about this was not pre-specified mapping. These are patients that had the procedure, they had clinical recurrence, they came back for a second procedure, and during the second procedure, the veins were almost all durably isolated, which is pretty good because you would expect some enrichment for reconnections. And then the Kaplan-Meier curve looks pretty good. If we go back to their slide, please. So at ERA, oh, I'm sorry, can you put up your slide one more time, Srini?
Yeah, pull up the slides again.
Yeah. So at ERA, this is a sub-study that Atul Verma presented from Pulsar. And so one of the interesting things about this technology is you're initially creating the anatomy. Of course, you can acquire electrical information. So when we retrospectively looked at this and looked at areas of low voltage, pre-ablation, of course, what we saw was that in those patients that had these areas of low voltage, shown in that, what is that, blue, teal, whatever that color is, the success rate from PVI was 53%, versus those patients that didn't have the low voltage, the success rate was much higher at 85%. Anyway, so Srini, you want to go ahead and show us what you're doing here?
Yeah, so this is just the 1-year results there. I don't know if you want to mention that, or I can just show you what we're doing so far. So basically, we've done a pre-map. Can you see that, Vivek, up on the upper left? You want me to make that image bigger, please? Just the main screen. So yeah, I did this before we went live, and this is. Can you also show the voltage that we did? Yeah. So I did those scans, the contact scan and flow scan, to identify the veins, and you can see it's a relatively healthy atrium. There's some areas near the appendage, for example, I don't have very good contact. So this is what we started with.
voltages,
Yeah.
can you clarify one thing? The voltages are measured as adjacent bipoles, or these are unipolars, or how are they computed? These are because the many poles together.
Actually, that's a good question. I always assumed they were bipoles, but now that you're asking me, I'm not 100% sure.
Are they bipoles? The voltage is bipoles?
It's a very good question.
Unipolar voltage.
Unipolar, okay.
Unipolar volt. Yeah.
And the reference is something inside the catheter, or
the reference is
we have an
IVC.
IVC catheter.
IVC. Okay.
And one thing I should note, just really quickly, Srini, let me just point out that mapping. This is not magnetic localization. It's based on electrical impedance localization. So as the device is being maneuvered in the chamber, well, there is some bulging. And part of the bulging is real because as you push against tissue, you deform it. And part of it is, well, frankly, it's the deformations that occur in the electrical field. Okay, Srini, please go ahead.
Yeah, so can you go to the video? So I want to show them the groin access here. So this is 20 French sheath, 21 French. And basically, we got, 21 French, we pre-closed it. And basically, and this is the catheter here. This is the sheath. We have ICE and a CS catheter on the other side. Let's go to the main screen, please. So Vivek, before we went live, I did the left side. I thought I'd show you how we do the right side here. So so I'm going to I'll put on X-ray so you can follow along as well. It's kind of an LAO. So I'm going to just pull the catheter back to get it off the left veins. I'm going to kind of clock it. You can see it interacting with the ice. So I'm going to pull the ice back a little bit and then just get that out of the way. I'm going to put a little flexion on this so I can get some good contact. So I'm going to then keep clocking, and then you see the RSPV coming there in the flow map up there. It's labeled as RSPV. Vivek, you see that?
Yeah, we do. And this is just for people to know. So as you're manipulating, the flow map is an easy way to sort of get a general idea of where you have contact and where you don't. I just want to, as you keep going, Srini, I just got a message.
Yeah.
So it turns out that it is unipolar, but it's unipolar against all the other electrodes. So all the other electrodes acts as a composite virtual electrode, and that's how this works. So, yeah.
Okay, that's going too far there. So let me go back. All right.
What's interesting about this technology is that it's it's a big ball. There are electrodes everywhere. So all you have to do is get it to that location. Of course, and once you have it in that location, it basically is, you can just pick the electrodes that you care about that in order to do the ablation.
Can I ask a quick question?
I'm going to go after the RSPV first. So can we do a contact scan there, please? So you can go ahead and speak.
I was just going to ask, so it certainly seems like an intricate system. How do you decide, as far as patient selection, which patients are best suited for this technology versus everything else that you guys have in-house?
Well, you could ask that about any technology, I suppose. I mean, look, this is a reasonably versatile
we have great
system.
Contact here.
Sorry, let Srini show. So you guys can see it up there in that top right bullseye. And then you're going to run a contact. That is a contact scan, right?
Yeah, this is the contact scan. So we just selected pairs of electrodes. So I don't know how many pairs we selected, but that's basically tailoring the lesion set around this vein. And so we got pretty good one shot.
Yeah, all those green dots there are the ones that are turned green. Energy will be delivered from those. So there's a few of them that probably are touching blood. You get a little bit of hemolysis, but mostly the energy is going to go into the tissue that you care about. But back to your question, I mean, so as you'll see, the PVI and this technology is very good because you know you have contact and you selected the electrodes and you get very good durability. But it also can be used to do other ablations. I mean, based on looking at that tissue today, I doubt he's going to do any more ablation, but you can certainly do posterior wall ablation. And we have an abstract where we've done mitral isthmus ablation as well as CT isthmus ablation.
And
So
it looks like here, compared to some of the single shot technologies, you don't necessarily have to be perfectly aligned. You can be kind of canted into it, and as long as you've got contact around the
right. So it is, and that's one of the nice things. It's directionally independent, right? So as long as you're pushed up against it, you pick the electrodes that happen to be touching.
What is the
I'm
pulse
going to
duration?
interrupt here. So
How long does
it was
take?
12. Was it 12
Sorry,
seconds?
Miguel.
The pulse duration. How many applications do you deliver in each vein, or is it one? And how long
So
does it take?
it's a train of 6, and it takes about 35 seconds to deliver. Now, if you decide to do the posterior wall, that you cut that down to 3. So it's basically, instead of 6, a train of 6, it'll be a 3. I just wanted to show you here the voltage map there. There's and you can see it's all red. The advantage here is not only you're seeing the voltage, you can actually pace from one of these if you want to. So like 3G or something like that. Can we just try that?
So just to clarify again, so it's a single 35-second application that has 6 different packets, let's call it.
And
Srini, two questions.
you see we have exit block right there, so you're not capturing the atrium there. Yeah, perfect. All right.
Srini, two questions from the computer. The first one, there are 2 vectors protruding from the catheter. What do they represent?
Yeah, you're talking about that vector there? It just shows the direction the catheter is pointed.
Pointing. And the second one is, in terms of maneuverability of the catheter, we saw prior with the Volt, you can deflate this catheter once it's, out.
Let's do this.
How do you move it? Can you deflate or you only have to rotate?
No, you rotate. So this is, go ahead, Vivek. Yeah, I mean, during the lesions, we don't deflate. I mean, that's just to take it's always this one configuration. We use the sheath quite a bit here to get into the veins we want. And overall, you can see it's not too bad to maneuver. It's not, it just takes a little getting used to, but I mean, we just went from the right superior to the right inferior right now. So we're going to do this. Oh, before you add the question for Miguel's, on top it says estimated ablation time, 35 seconds. You see as we go on, you're going to see what it's doing. Go ahead.
So, Andrea?
No, so talking about the duration, I mean, we learned that longer PFA increase the chance of thermal effect. I mean, we have, an example with the old version of Varipulse. So what is different about it? Because 30 seconds is probably the longest that I ever.
Yeah, it is pretty long, but the flip side is it's one application. That's it.
Yeah.
You have contact. So it's one, even in the study, it was 1.2 applications per vein. So it was really close to 1. The other thing is, and the reason it's 35 seconds, by the way, it's 6 packets with time in between. So it's bloop.
So yeah,
bloop. Yeah, exactly. So I think, and part of that has to be because of the cooling and et cetera. But, there does seem to be some advantage in sort of having this unidirectional delivery of energy because these electrodes are insulated on the other side. So the energy is going directly into the tissue.
And then outside of the energy delivery itself, obviously it's very sophisticated sort of contact assessment system here with the dynamic flow mapping and then a contact assessment. So how much of it is really that? I mean, because I think the durability data is obviously very impressive, but we saw the initial data and then started looking at, contact's important, let's try to optimize. This was already forward integrated, having that in place. So do you think a lot of that is,
is the contact?
Just the mechanism of assessing contact here, which is
I think so. I mean, I think that, look, one thing it's very clear is proximity is key when you're doing pulse field ablation. And, there's no better proximity than contact with tissue. And, it's true with this technology. The other one that I have experience with is the balloon with the endoscope, the cardiofocus balloon, where if you can see that you have contact with tissue, you're going to get a good lesion. So I think that, I think that, some of it probably has to do with the waveform. Some of it probably has to do with the contact. But I bet that when you have good contact, you get good durability. When you're not sure if your contact is good, you got to work more on the waveform or the positioning in order to get good durability.
Are there any situations where the atrium is very dilated or the pulmonary and ostia are very big? You end up being more closer to the ostium with this type of technology because you have to push it against the.
Well, it's pretty big. I mean, oftentimes, when you want to do a posterior, actually, he's going to do a little voltage map now, so you can sort of see what it looks like. It's you get pretty proximal isolation because yes, you're pushed up against tissue, but the tissue is not like it stretches away, right? It's still enveloped around the array.
Can you go straight PA, please?
There is in the computer again a question about too many choice for PFA. You know, we don't know what to use. But Vivek or Srini, I mean, this is another tool, and you know, we are seeing good potential for this as well. I mean, what if you have a true paroxysmal patient with a very small atrium? Would you have problem in maneuverability, or you say maybe, you know, actually 2 movement and you're done?
Yeah, I think, look, all I can tell you is what we know empirically. Empirically, we've been able to treat all these patients in a multi-center pivotal trial. All the patients were treated successfully, 100% isolation of the veins. So, yeah. Now, in terms of having too many choices, which is, you know, it's still an issue, I agree. What I would say is, look, we're still learning a lot about these technologies. Everyone has their strengths and weaknesses. On this one, hemolysis is a trivial issue. Contact is assured. So there's some good things about it. And, you know, I think with time, we'll sort of probably understand which is most important. Vijay?
Vivek, what about the size? Do you think if the atrium is too small, it may be a little difficult?
So, you know the size of this? This is the same as the cryoballoon.
Okay.
So it just looks much bigger because you have this sort of metal structure, right? But that, just to give you some idea of the size. So it's, you know, it's big, but it's not that big.
This area here. Okay.
But I think the only difference is that the cryoballoon, when we move it, it's usually deflated, right?
Yeah.
Yes, but you can deflate that, I agree.
When you do these maps, these voltage maps, do you do a quality control as to taking signals only when the electrodes are making contact by the temperature response, or just take all the signals?
Wait, I'm sorry.
When you're mapping now, there's voltage.
Oh no, when you're mapping, it's just taking
just whatever it comes.
Yeah.
You are seeing the vector go there. You know you're pushing, or?
No, I mean, the vector is just pointing the direction of that. It's, I don't know. You know, so the catheter itself does have a sort of a front to it because the shaft is on the back end. So that's sort of pointing in the general direction. It doesn't indicate force, so don't think about it that way. It's just pointing in that direction. Honestly, I forgot that it was there until somebody pointed it out.
Is this some sort of like true north marker?
Yeah,
like a line
it's like a true north marker, yeah.
With the sheath, I think. So it helps to orient you once you start moving it around to sort of get a sense of.
Somehow means something when something's pointing in a direction.
Yeah, so I just want to point out, so we did the voltage map here. It's just about the catheter. So it's not like completely in line with the sheath. There's always there's a little bit offset angle, and this is, if you look on X-ray, that's how it is. So the sheath is not pointing towards the tip of the catheter.
So I made one mistake actually, Miguel. So it actually is filtered. The electrograms are filtered through the flow map. So it's when in contact. So your intuition was correct. Devi?
Okay, so that was one thing I was going to say. And the second thing is the vector tells you which direction. When you deflect the handle, it tells you which way that globe is going to go.
Oh, okay.
So somebody is paying attention to the vector.
Srini, what are you going to do with the vascular access? Do you
so we pre-closed.
figure eight, or what do you do?
Yeah.
Pre-close.
Yeah, no, pre-close. Yeah, pre-close.
So Srini, we're down to the last 20 seconds or so. Any final thoughts?
Yeah. No thoughts. I think you see that.
All right, well.
I mean, I think it speaks for itself. It was one shot for each vein. You got the post-voltage map, and, you know, that's what it is.
Okay, fantastic. Thank you, Srini. Thanks to the whole team and the staff.
Yeah, thanks.